All right. So we have a couple more lectures that we're going to do with you guys. The first one's going to be intimate partner violence. So I think I went too far. Look at me didn't skip ahead one, but it skipped ahead two. What did I do wrong? It says definitions 2 of 2. Maybe I put them together. Let's pray that that's what I did. So domestic violence, what does it mean? Sometimes used instead of IPV, but includes other forms of violence such as elder abuse and, of course, child abuse. We know what victims are, I hope. They're the ones that have actually experienced a recent assault, and the survivor is one who's begun to heal from the assault. And the patient is the individual seeking healthcare related to the violence. So types, of course, we have physical and sexual. Physical is the use of an intentional use of physical force with the potential for causing, either death, disability, injury, or even harm. Now, when we get into sexual violence, we can kind of differentiate these into like some categories. So we can talk about rape or penetration of the victim. The victim was made to penetrate someone else. There can be non-physically pressured unwanted penetration, unwanted sexual contact, and non-contact unwanted sexual experience. So we talk about stalking, a pattern of repeated unwanted attention and contact that causes fear or concern of one's own safety or the safety of someone else. Stalking, believe it or not, can be in many forms, right? So we know that it can be like physical form, like I'm going out to stalk where Terry goes today or something, I'm following her. And it also can be, believe it or not, on social media.
Oh, absolutely.
So that's kind of really unique. So you got to really be careful what the definition of what that means. Psychological aggression, the use of verbal and nonverbal communication with the intent to harm another person. And that can be mentally, emotionally, or even having control over that other person.
Which happens a lot.
Yes.
A lot, and whether they're married or not, and just within that household.
Exactly. So sexual and reproductive coercion. Second, it's like a different category, a separate category that involves the use of power and control over or related to reproductive health. And there's two types. There's birth control sabotage, which is promoting pregnancy by interfering with contraception. So meaning like throwing pills away or, whatever that
Pretending to do something and, I've got an IUD, but maybe I don't really.
Yeah.
I mean, it can happen both ways.
Yeah.
On both sides of the party. So
Right. Pregnancy coercion and pregnancy pressure. So this could be like an act of violence or threatening behavior if a partner doesn't observe the perpetrator's wishes to become pregnant, continue, or even terminate a pregnancy. So it includes behaviors and tactics that pressures the partner to engage in sex without using physical force. All patients who experience sexual and even reproductive coercion are at high risk for long-term health issues, such as alcohol or drug abuse, sexually transmitted infections, HIV, and risky sexual behaviors. And we all know what all that can be risk factors for as well. So there's some theories. You guys can read about these. Family violence theories and feminist theories. The Walker cycle of abuse, you can look in your appendix 15A. So there's different phases, of course, like that tension building phase, acute battering incident, reconciliation, common loving phase. So epidemiology, there's some statistics surrounding this. Is 37% of all violent crimes experienced by women living in the United States. And 25 to 42% of all women will be physically assaulted by an intimate partner within their lifetime. And I think that's a little high, isn't it? It's kind of very disheartening, honestly, to see a statistic that high.
Well, and it sounds like it is, but when you come in contact with just people in your general day that have been in some way, even by somebody that they know, date raped or just, I see it quite a bit just in my practice. So it's sad
Yeah,
that that's what we're dealing with.
So they can also experience, there's statistics around sexual violence and then those with psychological aggression, which that's, to me, I could see that number, 36 to 57, that's pretty high. I could see that. Risk factors, it says we as providers should stop the cycle of abuse, awareness of risk factors, identify those women who are at risk and having those conversations. So interventions, one talks about plan for care should include differential diagnosis of pregnancy, coercion, and IVP, alternative resources and programs, creating that safe environment. What does that look like? How can we get your patient to that safe environment? What does a safe environment look like? Inform the patient about mandatory reporting laws surrounding what that looks like. Health impacts. Individuals and communities are, of course, affected. High economic cost, collateral health-related impacts, long-term effects, of course, could even be, I could see post-traumatic stress related around this. Having another partner later on down the road, and due to that. So clinicians should explore the possibility of sexual assault or forced sexual intercourse for all women presenting with any sort of gynecological symptoms. And it says multiple or persistent gynecological symptoms. Anybody that you would be really worried about that would come into your office?
Somebody who may, they may tell me during the pelvic, they may not say anything until the pelvic exam comes, and they may start squeezing their legs or their legs going in, I can't get where I need to be. And I realize their anxiety or they're very anxious about that part of it. And that's when it comes clear to me that they've been hurt by somebody that they know. In whatever way or fashion that you spoke of all those possibilities. So it's oftentimes that's whenever I'm finding out, because they're not willing to express that until it comes out physically. So if you were treating them for a STD, oftentimes find out what's happened. So
So, I had this patient in clinical one time who it was a younger patient, and her significant other came in with her to the appointment. Now, since COVID, you don't get a lot of that, because they're limiting, people who come into the room. He was adamant about coming into the room with the patient, older gentleman, very much so older than her, like probably 30, 40 years older than her. At first, I thought it was her father, but she clearly stated that was her boyfriend, would not let her speak.
Red flag.
In
a lot of sense.
Always.
The older, the coming in with her, demanded to come in with her. That's, most people don't have that attraction, that much age difference. But whenever I have somebody that the man's wanting to come in, or the partner, it's so I've enjoyed having COVID restrictions because no, I'm sorry, it's our policy, you can't come by.
So that's kind of one of those conversations that, of course, me and another provider had, was like getting him out of the room because he was not going to leave.
Exactly.
And so that just threw up so many red flags to us.
Absolutely.
And we're like, what we would give, but at what point, it's so hard.
And is it safe for her if he refuses to leave? You know what I'm saying? That what's going to happen to her after this appointment. So, I'm sure that there's some.
I'm sure we can keep going. threw that in there because it just kind of hits you like a ton of bricks. So screening and health history, of course, primary care settings during periodic examination and at all visits for any sort of new concerns. We always have to, ask what's going on. Most battered women do not come to healthcare facilities with obvious trauma or injuries.
Right.
It's always way after that
Exactly.
that they come to seek any kind of help.
And have you seen the posters like that we can post in the
Yes.
bathroom if you feel like you're abused and you need help, and the numbers for battered women's shelters. I had another agency I've just lost, but that's around that we can refer patients to if we have that opportunity, that they can memorize the number, or so that they have that opportunity that they can call if they need to or get away. But this type of person, it's very interesting how many times you expect them to get out of that situation and they're tied to it. They're sprayed, or there's always a reason why that they're not leaving that situation.
It makes you wonder even about their history and what, how they got into something like this to begin with, and why. And it seems like a pattern too. So they may get out of this one, but they go right into another one with maybe a different partner.
Right.
So always, trying to really clue into some of these things as a provider. So get a focused history, perform systematic physical examination, always be supportive. Sometimes they're not forthcoming. You've got to really build that rapport with these patients.
Yeah, and it may not happen the day you got her in there. It might be the next visit that you have to address this issue, because many times they're not willing to let out their secret.
Yeah, so true. Sadly enough, always. So screening tools, we need to screen periodically, including first prenatal visits, each trimester, and postpartum visits. There's different tools. You can read those. Do y'all have a certain one that you use that I know you don't do that side,
no,
but
and I'm sorry.
You're good.
Information,
I didn't know if you knew.
I don't see postpartum,
right.
and they want to follow up in their OB. So.
Right. So there's different ones. You can look at that and see. Traumatic brain injury also can be an issue with these patients. Unfortunately, there's a HELP screening tool that can indicate more screening is needed. So have they been hit in the face and the head? Emergency room treatment recently? Have they ever lost consciousness? Have they had problems with concentrating? Then we know there could be a potential head injury. And have they been sick after an injury? So that's the HELP screening tool. So part of your physical examination should be conducted like any other exam, of course. Look for like specific signs of injury, whether that be past or present. Is there bruising? Do you see bruising? Measure all bruises. Do you know what color are the bruises? Can you tell that they're old? You're going to ask the patient, well, what happened here?
I did that a lot. Oh my gosh, I've got to have that bruise. I hit myself on, a lot of them are innocent.
Oh yeah, of course.
Self injuries, but yeah, that's part of my life, because you can see it in between the leg where they've been grabbed.
Yes. Of course, mine's been weight recently because I've been doing weights and I'm like terrible. I don't work out. So I've just started this program and I'm like trying to work out. And so I have a lot of bruises on my legs where I go all the way down because I'm not used to that. And I'm like, oh my God, that's the weights. But it's funny. But anyway, most injuries affect the face, the chest, the breast, and even the abdomen. So kind of be looking kind of around these areas of potential abuse or partner violence. If sexual violence occurred, include a pelvic exam, right?
That was a sad thing. This was early in my career, and I can't remember what happened, how I handled it. I'm sorry.
No, you're good.
It was a young girl, and she had these bizarre looking burns on her genitalia, and I found out that her partner had used a hot light bulb to burn her
intentionally.
Oh my God.
And so she had
So
scarring.
sick.
Wow. Was she still with that partner? Okay. So assess immediate safety and provide any sort of referrals for these patients, especially before they leave. A thorough exam also includes their mental health aspects, neurological symptoms or system, gastrointestinal systems, and sexual and reproductive health. Document. It's imperative that we are doing some documentation. Document all findings in patient's record using correct medical forensic terms. Any kind of IPV history, be thorough and objective. Required components for documenting injury: location, size. What did they say before? Measure. Complete description of wound or injury, such as color or pain, because that will tell you if it's new or old. And photograph evidence of injuries using body maps and even diagrams if you need to.
And a lot of the medical, electronic medical records have that ability to document, even with a picture.
Good.
Photograph, yeah.
Good. And X marks the spot kind
Yeah.
of maybe.
Well, either
square.
or.
Okay, good.
Either or. There's a lot of newer ones that you can use your phone actually in.
Oh, it goes right
download it.
into
Yeah.
it. Yeah, I've seen
Yeah.
that.
I often use on my particular one is a diagram, like you're saying,
Yep,
and you
yep.
can actually draw with your cursor.
Yep.
What
And state what it looks like or what it
Yeah.
is. You can do a square over the area,
Yeah,
so to speak.
exactly.
Yep, I've seen that
different body
too.
parts.
Yep. So how do we manage these patients? And it says they're based on 4 principles: empowerment, to empower that individual to stand up for themselves and do something about what's going on. Look at their childbearing cycle stage specificity, abuse stage specificity, and cultural competence. Okay. Provide encouragement for them to seek help, numbers, options, resources, referrals. There's strangulation. That's reduction of blood flow to and from the brain due to some compression of the vessels in the neck. Common and dangerous form. Of course, it causes a variety of health problems. It's also difficult to detect, unfortunately. So the patient may have an immediate loss of consciousness, loss of sphincter control, and even start beginning to have some sort of raspy voice. So there's been damage right there of the vocal cords. Delayed symptoms include petechia on the face and eyes, right? You know what petechia is, even bruising, bleeding from the ear, and even other mental and physical health problems. So look up, be aware of signs and symptoms for this kind of strangulation. So unfortunately, look at that. 9% of adolescents report IPV. Sex trafficking, that is a thing, okay? It is a big thing of adolescents. Signs include history of multiple partners, frequent visits for reproductive health conditions, frequent testing for STIs, or even pregnancy. You've got to look for these patients. We've done numerous things here at LR, just even for the undergraduate patient population group. I've actually been involved with one of the primary care practices around here who had an issue with sex trafficking within the office. So you don't think it's around here, but it is within the community. You have to be aware and pick up on cues for these patients, because honestly, as the provider, you have to take care of this individual, because if they're a product of sex trafficking, they are in fear of their life, honestly.
Or their families lost.
100%, because they have been threatened, yes. Pregnant women, violence can increase or decrease during pregnancy. And of course, that can affect the fetus as well. Women veterans, look for these patients, do routine IPV screening, comprehensive IPV care within this patient population group. Women with disabilities, believe it or not, also, unfortunately, may succumb to IPV as well. They may be reliant on their abusive partner. They don't have another way out, period. shelters referrals to different agencies may be able to help these women kind of move forward and get out of that relationship. Elderly women, we all know that the elderly patient population group are also at risk for abuse, neglect, or even mistreatment. So cultural awareness, we have to know and be able to interact with sensitivity with persons from other cultures. We need to know what their cultural practices are, what's going on within their culture. Is this something that's abnormal? What does that look like? You need to be sensitive to that as well. So have cultural skill, and that's when you learn how to assess their values. It is okay to look it up, right?
There's culture that it's okay to have multiple partners. She may not have multiple partners, but he does, and it's expected.
Right.
Yeah.
Right. So look it up, and I'm telling you, it is okay to go understand about other cultures. They may see IPV differently, just what Terry just said. It's okay for my husband to do it. It's culturally accepted, blah, blah, blah. Screening tools should be adapted to those cultures. So you'll need to, if you have something like that in your practice, then you need to be looking for the appropriate tool to care for those clients. Prevention. Encourage change so violence toward women is not accepted. So we need to all embrace that and make sure that we're trying to prevent that at all costs. Place priority on development of healthy relationships across the lifespan, especially that parent-child relationship. For sure. Look at 15A, the appendix 15A for the 4 phases. We kind of talked about it already. So there's that tension building, the incident itself, reconciliation, and the calm phase. And then there's the screening tool in 15B in the appendix, partner violence screen, hurt, insult, threaten, and screen. And that's it there. So let's move into, last but not least for us today, is chapter 16. And this is sexual assault. So going into sexual assault, we have to know about the definitions. What happened to my... There I am. I'm like, what happened to my screen? It disappeared. All right. So sexual violence, sexual assault, and then there's rape. Okay. So you need to understand and be able to differentiate between these definitions. So I'm not going to read over that. I want you guys to understand those. Inability to consent may occur as a result of alcohol or drug intoxication, right? And so you guys are aware that sometimes people can drink or do drugs and they don't even know what's happening to them. So that could be even considered voluntary or involuntary. Unable to consent if younger than the legal age of consent, if somebody has a certain disability, if they're unconscious, okay? A third of women in the U.S. report some form of contact sexual violence during their lifetime. And nearly 1 in 5 women in the U.S. have been raped. And risk of violence differs among ethnicity groups. 35% have received treatment of their injuries, and 80% of the injured receiving care in a hospital, physician's office, or emergency room. So what do these patients look like, and what are the concerns that we're kind of like really cluing in on? These patients may not even seek treatment or seek treatment at a later time. Exactly. Why? Because they're ashamed, they're embarrassed, they're blaming themselves. Did I do this? Did I make him do this or her do this, or whatever the case may be? Maybe they know the perpetrator and they don't want to get them in trouble. Maybe they're uninsured. Maybe they're afraid. Maybe they just want to forget that it even happened, unfortunately. So we have to think about acute traumatic injury. Do they have any physical injuries? What are they classified? Are they mild? Are they severe? Do they have genital injuries, right? Lacerations, tears, abrasions, bruising. What about STIs, right? HIV. Pregnancy, 2 to 5% of rapes result in pregnancy. Prompt care is needed after the sexual assault. We need to think about psychologically, their psychological health, how to deal with the assault, long-term reaction, there it is, PTSD, and even substance abuse. So they go and end up doing drugs or illegal activities because of that. Sexual dysfunction is common, sometimes a chronic problem, right? And we've talked about that within these lectures today about having post-traumatic stress, and if that has
impact on their future relationships.
Exactly.
Yeah.
Exactly, because it is a problem. And, getting that history and finding out maybe what has happened in the past and getting them the help that they need moving forward, whether that be
And
counseling.
in my practice, it's oftentimes sometimes they'll come in like that, something's happened over the weekend. Whether they were drunk and then don't remember, or they feel like that they may have been drugged and they're coming into, they may not go into the emergency room, but they're coming into you just to make sure that they don't have any injuries or they don't have an STD or STI or whatever. So yeah, oftentimes it's after the fact for a while before I see them or know about it. Yeah.
So sad. So sad. So evaluation, there are medical forensic or clinical forensic examinations who actually are trained
Yes.
to evaluate women who have been sexually assaulted.
Some of my understanding that some of the hospitals and their ER have the trained providers, and they're usually nurses who have extensive training in order to collect the evidence or do the exam after the rape.
Absolutely.
For sexual assault.
Absolutely. It includes a complete history, a general physical examination, anogenital exam, and evidence collecting. So they have everything that they need to collect evidence related to the situation. So providers need to treat women's injuries, address any sort of health-related concerns they may have, coordinate with crisis intervention, get that evidence that you need. Okay, maintain the appropriate chain of custody, especially, if we're talking about a minor, even. Follow jurisdictional reporting procedures, whatever that looks like, and testify in legal proceedings if need be.
I've never testified in legal proceedings, but I have called DSS before when I suspected there may be something going on.
Wow. And I think it's our responsibility to do that. So I think we have to be prepared for that. Okay, consent. There's two types of informed consent. We have general, and then which is consent signifies the woman has agreed to receive medical evaluation and treatment. And then second type of consent grants the clinician permission to collect evidence, gives the woman the option to release the evidence to the appropriate law enforcement agency or criminal justice agencies. So confidentiality and reporting, we have to maintain patient confidentiality no matter what, unless it's legally required to report something to law enforcement. So you need to know what your agency is requesting.
Well, such as a minor.
Exactly.
When you're suspecting abuse and they're underage.
Yep. Exactly. Patient history, you have to collect information related to the chief complaint, any information surrounding the sexual assault, and general medical information, which is pertinent to the assault. Do a psychological assessment. You always have to see what's going on psychologically with these patients. Do a general physical exam. So collect clothing before the exam and document and photograph the woman's injuries. Okay. Anogenital examination includes the perianal tissue, external genitalia, internal genitalia, even a colposcopy, I would think, and dye help identify injuries.
Which is just microscope, basically, on the skin.
The evidence collection, you have to carefully collect the evidence, maintain chain of custody, collect a known sample, hair samples, right? Body samples, oral and anogenital swab, and smears. And that's probably trying to identify DNA or something that's left on the patient, right? Documentation, thorough documentation, I can't tell you how pertinent that is, right? Medical records includes all information from patient's admission. Evidence, the kit report includes evidence collection, consent form, a history of the assault, any information pertaining to the evidence collection to assist the crime lab to analyze these samples. So you have to have everything in place. Diagnostic testing includes STIs, pregnancy, and a toxicology screening. Involve the victim advocates to provide information and referrals, ensure safety following any kind of assault. So you want to make sure the patient is safe. Advocacy services, Victims Advocacy Agency can help provide services to help her deal with the acute and chronic consequences surrounding the event itself and offer support and assistance moving forward. Safety plan and help her contact law enforcement office or enforcement agencies if need be. Make sure she has a safe place to stay, and support systems are definitely necessary. You don't want reoccurrences to happen. You want her to feel safe. Legal advocacy may also be needed, so she may need to talk to somebody.
Yeah, and there's a agency, Safe Harbor, in the area that will work with women like this and provide a safe place for them.
Referral to sexual assault forensic examiners. This says that examiner, so a provider who has completed the required didactic and clinical training to care for sexual assaulted patients. And that's what we talked about. There are people who are actually trained to obtain all this evidence. There's also a sexual assault nurse examiner, a registered nurse, which you just talked about, who performs all that components of the medical forensic exam, psychological and physical management of the patient, and relevant patient education. So when we talk about psychological health, during the evaluation, the provider should assess the level of orientation, any kind of suicidal ideation, need for referral, for follow-up support, evaluation, and or treatment. A watchful waiting approach may be implemented in which the women engage in follow-up appointments with the referral agency. So you're just kind of continuing to follow up with these patients because they could always take a turn for the worse, and you want to make sure you're getting it on the forefront.
Right.
Pharmacological management. If there is indeed an STI that you have found during your examination, of course, you're going to treat these patients, right, appropriately, whatever you found. HPV vaccinations, we all know about the series of 3, and any kind of antibiotic therapy to prevent STIs. HIV prevention, if there is a risk for HIV or the patient or client feels like that they may have been exposed or worried about, who they came into contact with, then they're given NPEP or NPEP as soon as possible. Pregnancy prevention, emergency contraception, and that's only if that's given within that time period to which sexual intercourse may have taken place. So that's 120 hours of assault, because efficacy, of course, decreases with time.
You can get that over the counter now.
Yeah, Plan B, right?
Mhm.
Yeah. Pain medication is offered if needed, and that depends on what kind of injuries that they have sustained, and that'll tell you, what's warranted. Give woman oral and written instructions about her care. Make sure she's coming to follow-up appointments. refer her to agencies that can help her develop a safety plan. That's so important. Safety plans are so important for these patients. Medical follow-up absolutely should occur within 1 to 2 weeks after the assault itself. We need to find out how these patients are doing, assessing for STIs, making sure they've completed their treatment regimen. Call them by phone, and it says, or text message within 24 to 48 hours after that initial evaluation to assure that they are following up and they're complying with your medical treatment plan. Then, of course, special consideration. What's the age of the victim? Are they very young? Are they very old? They may rely on their perpetrator, unfortunately. We need to get those questions answered. They may have difficulty describing the incident and relating symptoms, and that depends on what all transpired. You know, was it alcohol involved? Was there drugs involved? The disability population group, it's mandated in every state to report those. So they could be individuals with cognitive and developmental disabilities may not be able to give informed consent. So adaptive devices may be needed for people with communication or physical disabilities. Your LGBTQ individuals, many sexual assaults are not reported because their fear of being judged by the police or rejected by other people. So provide them referrals to agency skilled in caring for this patient population group. Always remember that there are cultural differences that we need to know about and be aware of, because that can cause distrust and language barriers. Making accommodations for their culture and also providing an interpreter to make sure that we're having those conversations. Sex trafficking, it is out there and you have to be aware of it. So look at this patient population group. What's the process, the means, the goal of obtaining a person for the purpose of a commercial sex act? 80% of human trafficking victims are women and young girls. Considered modern day slavery. Prevention involvement at primary level can prevent some assaults. So challenge behaviors that promote violence, identify those risk factors and those individuals at risk, and educate your administration and even your staff on these patients. Look at your appendices. There's some great things there. There's some provider resources, signs and symptoms of strangulation, and the body diagram. I know that I'm going to end this lecture with Terry talking about a specific patient that she had come into her practice that would be a good share for us to kind of talk about. Yeah, good with that.
So, a longtime patient I've seen, she's a single woman. She's postmenopausal, and she, from time to time, it has different partners, but she came in and reported that she needed to talk to me, and my assistant put her in, and she said she's not telling me what she really needs. So I had to be careful. I knew it was going to pertain to sex whenever she won't tell the assistant what's going on. So anyway, it came to find out she was having consensual sex with a partner that she has seen off and on. And it must have been a position that they were in that he forced her to have anal penetration, and before she even knew, and before she could stop him. And then must have gone back into her vagina, but she was there. She was emotionally upset with what had happened. She is not tied to this partner, so she is not planning to be with him again. But her main concern was, what did he do to her? And what did he give her? Meaning infection.
Yeah.
And she was crying. She was tearful. I asked her about was she planning on hurting anybody or herself, and she wasn't. she wasn't to that point, but visibly upset. So I had to, thankfully, she shared what had happened to her. And so that helped me to know how to take care of her. So, and I told her everything I was going to do. So I said, I'm going to examine you, and then we're going to test you for some infection. So I tested her for gonorrhea and chlamydia. We did a vaginitis swab because that includes trich. And the possibility of infection because it goes back into her vagina. I've looked for anal trauma. I did a digital exam to make sure that I couldn't feel anything. And I also tested her for occult blood after digital exam to make sure there wasn't any tears up inside, but also it helps to reassure her. She did test the anal for possibility of infection as well for STD. So anyway, I found out that she's not in danger now, and she won't see him again. He saw it as casual sex. She saw it as rape because he forced her without her consent. So
I think, we have to be aware of situations and what we may encounter, right, and in practice. So I want to thank you guys so much. I want to thank Terry for all of her help with these modules and delivering those to you guys. I hope you guys have found some really good take-home things from what we have discussed these past couple weeks, and want to thank you for listening, and we'll be in touch soon. Thank y'all.